Hello, everybody. My name is Kyle Klarich, and I'm a cardiologist and consultant at Mayo Clinic in Rochester, Minnesota, coming to you in the form of interviews with the experts at Mayo Clinic. And today we have a very exciting topic, AI in imaging, and how will it change what we do? And we are very fortunate to be joined by our expert today, Dr. Timothy Poterucha, MD. He is an assistant professor here at Mayo Clinic in Rochester, where he is a general cardiologist, an echocardiographer, and an AI clinical researcher. Dr. Poterucha has his medical degree from Mayo Clinic School of Medicine, followed by residency in internal medicine at Brigham and Women's Hospital, Harvard Medical School. He then completed both his cardiology and his echocardiography training in cardiac ultrasound, heart ultrasound, and fellowships at Columbia University. While at Columbia University, Dr. Poterucha created a research laboratory that focused his interest on AI analysis of EKG and also echocardiography, with a focus on deploying those AI models to improve disease detection across medical systems. You probably know, but I'll just emphasize his work has been published in the Journal of the American Academy of Cardiology, Circulation, and the European Heart Journal. He joined our faculty here at Mayo Clinic in 2025, where he has focused on moving AI analysis of echocardiography into clinical practice. So, Dr. Poterucha, Tim, welcome to Interviews with the Experts.
I'm glad to be here, Kyle. Thanks for having me.
Well, we're very pleased to have you. And I think I'll just start out with letting you tell us a little bit. Maybe there's people that, I mean, everybody hears about AI every day, right? We can't hardly turn on TV or shopping or anything else without AI. But artificial intelligence, or AI, is beginning to reshape cardiology and different things in our practice. Could you just kind of give us a little overview of what that means for the average clinician cardiologist going forward, or how you see the future, maybe?
Yeah, absolutely. So let's talk about the big picture. For most of human history, the only way that we had to interpret information, whether that was words, images, uh, ongoing activity in the real world, was the human eye and the human brain. That has really changed dramatically over the last 10 or 15 years. And I think it broadly fits within the larger story arc in the innovation in cardiovascular imaging. So, first of all, artificial intelligence is simply a set of techniques that try to teach computers to interpret information in a way that is intelligent. That's like what you and I do. It encompasses a broad range of techniques. This includes simple rule-based things where we ask, yes, no questions. Is this information consistent with this problem? To more complex techniques that try to take a look at a large series of images, videos, and text and make a very complex interpretation. So let's think broadly about innovation in cardiovascular imaging. So echocardiography, what I spent a lot of my time doing, was first developed in the 1950s to try to answer the very simple question of which patients with mitral stenosis would benefit from a finger valvuloplasty, where the surgeon would open up a stenotic mitral valve through the first open heart surgeries. It was known for a long time that many of these patients actually didn't benefit from this technique, and it was due to concomitant mitral regurgitation or leakiness of the mitral valve. So, echocardiography was developed to answer this question of which patients with mitral stenosis have mitral regurgitation. Since then, it's been one continuous pace of innovation after the other. The initial techniques were quite crude, and that led to the development of two-dimensional B-mode imaging, stress echocardiography, color Doppler, 3D, intracardiac, and intraprocedural imaging. And as a result of these advances, echocardiography has become a major public health tool. It's the single most important way that we diagnose structural heart disease, or at least the most common way that we do, with tens or hundreds of millions of studies performed every year around the world. These same arcs of innovation can be told across every modality in cardiovascular imaging, whether that's cardiac CT, cardiac MRI, angiography. the pace of development has been truly extraordinary. I think that AI is set to continue this story of innovation because it gives us truly a different way of looking at these images. Like I mentioned earlier, for a while, it relied on the human eye and human brain. And now we have the ability to develop tools that can look at these images and get profound insights that might be different than the way that we can do them as humans. And I'm very excited to continue to explore that.
Yeah, that was a really great summary. I really appreciate you going into that kind of historical longitudinal view of mitral stenosis of all things, and kind of putting it into clinical realm. I go back to how did you get interested in this dramatic area? I mean, we don't get a lot of training, at least probably recently. It's become part of I know we teach in the medical school, and the medical school is now imploring us to bring AI into our curriculums. But when you were in medical school, when I was in medical school, no one even thought about AI. How did you get interested in it, and how did you blend that with your current research interests?
Yeah, so when I was a cardiology fellow at Columbia University, I had the opportunity to present this paper that was published in 2018 in Circulation. That was the first serious attempt to apply AI to echocardiography. This paper sought to explore ways to calculate the ejection fraction by making segmentations of the left ventricle through videos and make some rudimentary disease analyses, like which patients are likely to have cardiac amyloidosis or pulmonary hypertension. When I presented this paper at Journal Club as a cardiology fellow, it was clear to me that this was the single most important paper in medicine that year. It wasn't initially seen as that. It was seen as an interesting computer tool, but it represented something that was profoundly different, that you could have a computer look at these images in some way that could achieve really unique and novel insights. And after I presented that paper, I had no choice, no personal choice other than to dive deep into this subject. So, with one of my co-fellows at Columbia University, Pierre Elias, we decided to go about building an AI research lab. Now, at the time, we looked around for people who are doing AI at Columbia University, and there was no one. So we decided to go about and do it ourselves. He would get some additional computational training, and I would focus on the clinical aspects of imaging with additional work in echocardiography and training in clinical trials. And we slowly, over time, built a research lab that focused on AI analysis of ECG and echocardiography. Some of this work was to replicate things that we already do, like using AI tools to assess how much mitral regurgitation is likely to be in a particular video or a particular study. But some of it is truly novel, where we ask questions that people simply don't, like which ECG is likely to be from a patient with structural heart disease, or how can we predict the future of patients with mild and moderate levels of valvular heart disease and identify those patients that are most likely to decompensate over time. And I'm thrilled to continue to explore that work here at Mayo.
Yeah, I think that's an amazing story, and that it does take someone to have something like that really motivate them to take on a challenge like this because 2018, that was not that long ago, but so much has changed, and you and I have both experienced how EKGs can sort of predict the future and in patients in our practice, such as atrial fibrillation, the ejection fraction likelihood of being low. But I'm sure in all of this, you've realized that there are some problems with how we interpret, especially imaging now, and how that would maybe affect your foray into understanding how AI can help with echo. And I think you're still doing work in EKG, but feel free to speak on either of those two areas. But it's nice to know both the hope of AI and also potentially problems that we may have with AI.
Yeah, so let's start with the problems with interpretation of medical imaging as it exists right now in kind of the broader secular trends. So we have a population that's getting older,
Mhm.
that's getting sicker, and we've had no change in the number of providers in healthcare to deal with these problems. So every patient that we see, of which there are many, is more complex and has more need for medical imaging services. So there are several use cases for what I can think of for AI in medical imaging. So the first is to increase efficiency. There are just more studies that need to be done, and we need more help to do them. The second is cost. More studies are going to cost more. They're going to require more resources. So AI could conceivably be used to increase efficiency and reduce costs. Third is interpretation of these studies is time consuming. When we sit down and
Mhm.
read echocardiography, we can interpret anywhere from 20 to 35, maybe 40 studies a day at the upper end.
Right.
And with more studies that are each getting more complex, there's just more need for tools to help us make it our way through that backlog. In addition, there is an unspoken about incredible amount of intra-observer and inter-observer variability. When I read the same echocardiogram now versus tomorrow versus the day after, whether it's before lunch or after lunch, we know that there's going to be differences in my interpretations. That's intra-observer reliability, differences within me. And when you and I read studies apart, there's going to be differences in how we interpret them. This decreased reliability leads to the same study being interpreted different ways over time. And that's just not going to be good for patient care. So AI may be able to help us across all of these domains.
To actually become more consistent as an intra or inter study kind of checkpoint, maybe.
I think so.
Yeah, very cool. What is the hype right now in echo and in EKG, and are they real? Or I kind of think you've already touched on this to a certain degree, but um, the what is going to be clinically useful right now versus where you see the future.
So I think right now, if you order a cardiovascular imaging test, there's actually going to be a pretty good chance that AI was used in its interpretation in some way. In echocardiography, almost every one of our carts, whether that's Philips, GE, or other vendors, has a series of AI tools that help us do things like automated segmentation to measure the left ventricle, measure the left atrium, to calculate a biplane ejection fraction, left ventricular ejection fraction, or to do things like strain. We forget that almost every strain package is itself an AI tool for determination of the global longitudinal strain, which is another marker of left ventricular systolic function. So it's very possible right now that many of us may be using AI tools without even realizing that they're AI.
Yeah.
There's an incredible amount of things that are extremely exciting on the image interpretation side, not just acquisition side. So, for instance, when we do a coronary CT scan, that coronary CT scan is first visually interpreted by a radiologist or cardiologist, trying to determine the degree of stenosis, the degree of narrowing inside of each one of these blood vessels. If there's a spot that's concerning for a significant narrowing, we can send that CT scan for AI analysis at one of the companies like HeartFlow or Cleary. These companies can use a prediction to determine whether a area of blockage is likely to be severely stenosed and benefit from revascularization with stenting or with bypass surgery. These technologies offer the ability to provide additional information on the scans that we're already performing, and we're already finding that it's starting to change our practice.
That's amazing. It really is. And I would agree with you. I think there's a lot of the things that we're using in day-to-day practice that are AI running in the background, whether it be our Google searches or whether it be, medical searches or like you pointed out, the strain imaging, things that we don't really identify as AI. But there probably are some risks. Can you speak to what their risks of AI are?
Yeah, absolutely. So, what are the risks and what's the hype? So, let's start with the hype. Although there are some really promising research papers that have come out, particularly over the last several weeks, in complete analysis of using AI to completely analyze an echocardiogram, I think the idea that studies are going to be acquired and then automatically interpreted is almost science fiction. When you think about how we spend our time interpreting medical imaging, a lot of what we do is trying to interpret a study in the context of a patient or to interpret a study in the context of its limitations and the limitations of the sonographer who performs the study
Hmm.
and the discussion with the sonographer in order to improve quality. Those things cannot be replaced by AI tools, or at least not yet, not for at least many years down the road. So I think the idea that we're going to have complete automated interpretation that's going to completely remove us from the equation, I think still is science fiction. However, talking about the risks, there are going to be this period of time where these AI tools are incredibly potent, but still incredibly fallible. And I actually don't think it's a given that AI interpretation plus a human is any better than human alone. Our interpretations of medical imaging as humans have been optimized over many years of training, and AI is new, and its integration into tools is likely to produce new types of errors. So let me tell you about one study that we did using AI analysis of ECG for detection of structural heart disease. This was published in Nature over the summer. In one really interesting analysis, we took a series of 300 ECGs and asked clinicians, 13 cardiologists, board certified cardiologists, to interpret each ECG and try to make a determination of whether structural heart disease is present. So, this isn't a technique that humans have necessarily been trained on, but we think that we do a pretty good job of looking at an ECG and trying to find the ones that are really abnormal. So the cardiologists as a whole had an accuracy of about 64% for the task. Not great. And the AI tool alone that was developed for this task had an accuracy of 77%, suggesting that the AI tool was as far away from cardiologists as cardiologists were away from random chance. So we can develop AI tools that can do this task really well. But when we gave the AI information to a cardiologist and had them reinterpret all those ECGs, their accuracy was only that in between that of a cardiologist and AI. The AI actually by itself would have done a better job at this task. So I think we have to figure out how to
Hmm.
manage powerful AIs that can do certain things particularly well, but might have big blind spots that need to be explored. There's this concept of automation bias where people will trust an AI output even when they necessarily shouldn't, and own information bias where we discard the AI results without thinking about them and trust our own intuition. There's probably a sweet spot that balances these risks of using these tools plus not. And that area is one that we're going to have to be very careful to thread.
That's a really good point. It was interesting to me that if I understood your analysis there for the EKGs, that the cardiologists were 64%, but the AICG was 70 something. Neither of those sound too good to me. I don't know.
Yeah, yeah,
A
I think you're right.
little bit better,
They're
but
imperfect, and we don't really think too much about how our clinical interpretations may be imperfect. Now, that being said, you and I have the advantage when we see a patient of doing a physical exam, hearing
yeah.
a story, interpreting things in the context of their past medical history and their symptoms. So I think the ability for us to operate outside of just interpretation of a single modality is one of the key strengths that is not going to be quickly replaced by any AI systems.
Sure.
All right. Or if it does, I hope it does better than 64% accuracy.
I agree. Speaking of replacing, do you think that their AI will ever replace cardiologists, or for that matter, any, you mentioned technicians, but of course, most of our listeners are cardiology uh, trained, and the fellows might be worried about what's going to happen to their job security going forward, 40, 50 years from now. What do you think?
Yeah, so I think about once a week, I have a conversation with a fellow where they ask me whether echo is still going to be a field when they're done graduating echocardiography fellowship in 3 years. And I usually tell them that echo is still going to be a field in 50 years. It's still going to be around. It's still going to be just as important. And humans are going to be just as key to the process as they were before. But I hope that the nature of our work gets changed a little bit. I have to say, the best part of my day is usually not interpreting a stack of images and trying to look for the trace pulmonic regurgitation or doing extensive quantifications on the severity of mitral regurgitation. Instead, the best part of my day is interacting with the sonographers, trying to make sure we get the best possible study and speaking with clinicians about the importance and the limitation of those results. Those are the enduring human roles: lab management, supervision, integrating integrating images with clinical context, communicating with teams and with patients about their results. I don't think any of that's at risk for being replaced by AI, or at least not the kind of AI that we can conceivably develop in the next decade. Things I do think are likely to be assisted or maybe even replaced include segmentation, drawing the borders of the left ventricle to calculate a biplane ejection fraction, maybe workflow optimization. And I hope that we have tools to flag particular studies as likely to be from patients with undiagnosed diseases. I had the opportunity to present a study at the American Heart Association meeting that was published in JAMA Cardiology that used an AI system to try to detect cardiac amyloidosis across a healthcare system, used ECGs and echocardiograms. And what we would do is take this system that was trained in retrospective data sets that had been developed in the past, and then we applied it across across the entire healthcare system for an entire year, trying to find the needles in a haystack of patients with undiagnosed cardiac amyloidosis who are walking around undetected with this disease. And what we found is this AI system could accurately find these patients, but it was an incredible amount of work to figure out how to implement this AI system inside of the healthcare system where you could use these analyses to actually go out and get those patients, to bring them in for testing, to integrate them inside of care. Those things are where we need to go with these tools. We need to not only develop great models that look at images, but also figure out the clinical systems that are going to operate in a very heterogeneous environment to improve clinical care around the world.
Yeah, I think that that's a really important point. That what we're trying to do is, in many of these models, identify patients that might benefit from earlier treatment because they're flying under the radar under the usual clinical scenario where the patient nor the clinician really get any history from the patient that they have symptoms because it's premature, right? It's
Hmm.
preclinical, and but yet we know many of our therapies can be very much more advantageous if we treat patients early before the disease really gets a foothold. So that's extremely exciting. One other question that I'd like to ask is about potential biases in AI. As these models are developed, is there potential for biases, and how do we guard against it if you say there are?
Yeah, absolutely. So I think there have been two really important analyses looking at potential bias in AI. Um, so the first was looking at data sources. So we know that these AI tools have problems interpreting information outside of their training context. So when you train an AI system, you want to have as broad of a range of possible of information to train AI that's going to work within a generalizable data set that's going to work outside of just the information it's trained in. When you actually look at the data sets that are used for training of medical imaging, almost all the information as of about 5 years ago had come from three states in the United States. That's Massachusetts, New York, and California. So there's this concern that you may, when there's all the data that's used to train these models is just from a few centers, it may actually not be able to be generalized to other populations. So that's the first concern is data bias, where
Mhm.
the data is only from a few areas and isn't generalizable. The second is concerns about replicating bias that's already present in the healthcare system. So we know that the way that healthcare is practiced is prone to both conscious and unconscious bias, where certain populations of patients are treated differently. If you train an AI system to operate like the current healthcare system, there's a risk that you're going to, instead of improving, you may perpetuate those biases where certain groups of patients are excluded from further healthcare because it's just replicating what's already happening. So I think those are the two biggest concerns I have is replicating biases or entrenching them that are already in our healthcare system and making sure that these AI models work in a generalizable way across all healthcare systems.
Yeah, that's a really important point, I think, that we need to be very cognizant of going forward. And as you point out, these are earlier studies and things are being done more broadly, I think, across the country at this point in time, which is fantastic. And maybe I'll end with, what's your vision for the future? in terms of AI, and any other comments that you might want to make about this very interesting and important topic.
Yeah, so right now, I think there is going to be more need for imaging in sicker and more complex patients. Our our healthcare workforce is not growing, so we're going to need some kind of tools to help us meet that need. I think that in the next 5 to 10 years, every imaging lab is going to have a full AI layer working behind the scenes, providing preliminary interpretations, interesting analyses, looking for particular patients with diseases, and doing that routine work of measurements and segmentations entirely independent from people. However, I think that we're going to keep the final decision-making authority still firmly in the hands of human clinicians. I don't think that is ever going to change. Our patients don't want it to change. They want us to continue to be involved closely in their care, closely supervising the results of AI. So I think the future is bright. There's more need for cardiac imagers than ever to meet this growing need, and AI is providing an additional way to analyze these studies in a way that's going to allow us to continue that arc of innovation and continue to provide excellent care to our patients.
Well, thank you very much, Dr. Poterucha. This has been a fascinating and really insightful discussion about a topic that I think we do hear a lot about, but we are going to only hear more and more. And I think you've also alleviated a lot of the fears that many of our trainees and possibly some of our sonographers also have looking into the future. So I think it's a very positive outlook using AI, and we'll ask you back in the next few years to give us an update. How about that?
Looking forward to it. Thank you, Kyle.
You're very welcome. Well, I appreciate all of our listeners joining us today for this very interesting topic on AI, and hope to have you back in the near future for our next topics. Have a great rest of your day wherever you are.
At Mayo Clinic, learning fuels world-class care. I'm Dr. Peter Noseworthy, Chair of the Division of Cardiac Electrophysiology. I hope you enjoyed today's episode, and I want to let you know about the full courses that we have available. Head over to cveducation.mayo.edu and explore our live and online programs, quick on-demand modules, and CME-accredited masterclasses. Join the thousands of clinicians who have already turned their curiosity into expertise at cveducation.mayo.edu.